All right. So the characteristics of normal breathing. Now, it's very important, and this is how it works. You need to learn the structure. You need to understand the function, and then you will be able to differentiate or pick up abnormal function. If you know what is normal, anything outside of that would be abnormal, and that's what we call pathophysiology, right? And your patient will present with pathophysiology. So when a patient has a problem, that's what you're going to see in their presentation, the opposite of normal. It's something bad. So let's look at the characteristics of normal breathing. All right, so first of all, we need to look at the rate and the depth, right? So rate is how many minutes per minute the patient is breathing. And the depth is whether or not you're able to see adequate rise and fall of the chest. That's tidal volume. We need to determine if the rhythm is regular. And when we look at a rhythm to determine if it's regular, we're thinking about consistency. So do you see a consistent pattern of rise and fall? Let me repeat. Everything that I'm saying to you now are things you'll be expected to answer or demonstrate when you're doing your practical. So this slide is extremely important. So normal rate is how many breaths per minute the patient is breathing. Tidal volume or depth is whether or not you can see visible chest rise and fall. Rhythm regularity has to do with consistency. You see a consistent pattern of inhalation and exhalation. So is it that you're seeing one pattern in terms of movement of the chest, or you're seeing it speed up, then slow down, then pause, then speed up? Are you seeing an irregular pattern, right? Is the lung sounds clear, right? So do you hear abnormal sounds without a stethoscope or auscultation? Do you hear abnormal sounds when you auscultate the lungs, right? Or is the lung sound clear bilaterally? They always go bilateral. So you always compare right to left, right? As you move down. Can you see bilateral movement of the chest wall, right? So does both left and right rise together? Or you see the right side rising and a portion of the left moving in. That's paradoxical motion, right? Is there movement of the abdomen, which you can see that in your pediatric population, right? Now, at this point in time, the normal breathing rate for an adult is approximately 12 to 20 breaths per minute. The younger the patient, the faster they will breathe. So adult is about 12 to 20, child 15 to 30, infant 25 to 50, right? These are approximation. So we don't, numbers are, you're gonna see a lot of numbers in your textbook. Don't get too caught up on numbers. Numbers are there for a reason to guide your assessment. right? But you always have to consider the numbers, but you also need to consider the patient presentation, right? You have to consider the patient presentation because a patient can be breathing. Let's say the patient is breathing at 14 breaths per minute, but the patient don't have adequate tidal volume. If the patient don't have adequate tidal volume, that's not a normal breathing pattern for that patient. Yet the rate is within the normal range, right? So when you look at rate, you also need to consider presentation. Does the patient presentation match the rate? Very important. We don't treat numbers. So in EMS, we do not treat numbers. So when you're doing an assessment where numbers are involved, you look at the numbers and you look at description and presentation, right? They must be connected. So that's a normal rate. You look at the chest rise. Is there visible chest rise for this patient? And once you're considering visible chest rise for your patient, you need to also consider what is the patient's level of consciousness. Is this patient unresponsive? Is this patient responsive? Is this patient semi-responsive? So you must always consider the patient's level of consciousness or mental status, right? Now, all of these components must be considered before you determine if your patient is having a breathing issue, right? If you only look at one or two components, you're not doing a full assessment. If you have not done a full assessment, you cannot provide appropriate treatment, right? Because it goes back to the functions that we looked at. You must evaluate ventilation, right? And when we're evaluating ventilation, we're looking at the rate that the patient is breathing and whether or not there is appropriate tidal volume, whether it's regular or irregular, right? When we auscultate or listen for long sounds, we are evaluating respiration, right? That's what we're evaluating. Does this patient have good respiration? So if you hear wheezing, you hear rales or rhonchi, which suggests mucus or pus in the alveoli, air cannot pass through that, right? So if the patient has something occupying the alveoli, oxygen exchange cannot occur. So we are assessing respiration at that point. When you put on your pulse oximeter, which is a device that measures the oxygenation level within the capillaries, you are measuring oxygenation. So you know the function, you must be able to assess whether these functions are present. And if you have not looked at all of these components, you have not determined effectively that your patient has a breathing issue and you don't know what the treatment should be, right? So if it's ventilation, if your patient has a ventilation problem, then you must create the ventilation for the patient. It means you must breathe for that patient, whether you're going to use a pocket mask, whether you're going to use a BVM, you have to breathe for the patient. That's the treatment. If there is a if there is an oxygenation problem, the treatment is give the patient oxygen, right? Patient having an oxygenation issue, give the patient oxygen. If the patient has fluid or pus, let's focus specifically on fluids in the lungs, you're gonna need more than oxygen. You need the oxygen, but the oxygen has to be administered under specific force that is going to increase the pressure inside of the alveoli to push the fluid out of the lungs. So the management becomes very specific depending on what is the problem. And that is based on your assessment, right? It's based on your assessment. Now, I've seen some horrible assessments, right? I've seen live horrible assessment, and I've read some reports that suggest horrible assessment, right? There's no way you can look at a patient and know what is their ventilation, oxygenation, and respiration status and just fling oxygen on them. It don't work like that. Oxygen is a medication. So you must determine that there is an indication for that medication, right? And that's a common practice in EMS, especially when persons start to panic. And once you start to panic, you're gonna make mistakes, and sometimes these mistakes can be very critical, can mean the difference between life and death for a patient, right? So you need to do your assessment, and we don't use shortcut business. There's a lot of shortcuts, right? And that's bad practice. If you're supposed to check the breathing rate for 30 seconds and multiply it by 2, that's how you check the breathing rate. If it's irregular, then you check it for a full minute. You are not supposed to be checking a breathing rate for 5 seconds or 15 seconds. You're not going to get an accurate reading. You can't look at a person breathing and guess that they're breathing at a rate. You have to check it, right? So a thorough assessment is important, and I will be looking for all of these components when you are doing your assessment on a patient that is having a breathing issue. So again, if you can clearly identify and understand what are the components of normal breathing, it will be very easy for you to recognize when your patient is having trouble breathing, right? So, Mr. Zandre Powell, when we talk about rate, what is your understanding of that?
Well, my understanding of rate is the regularity. So like the breathing, you don't see any discrepancies, like you see a speed up, a slow down, or should I say acceleration and then a deceleration in a person's breathing. You see it's maintaining a particular rhythm.
I only asked about rate.
Yes, sir.
Right? So you guys need to pay attention to what questions you're asked. Your ability to pay attention is extremely important in EMS. All I asked was rate. So your answer should be specific to rate. This is how the questions will be set in your exam. You have to focus on what is being asked or what is presented. And ask you about rhythm, ask you about rate. What's your understanding? All right. Mr. Manning, what is your understanding of depth or tidal volume?
All right. In regards to depth and tidal volume, that would be the adequate rise and fall of the chest.
Okay. How would you determine that if you had the patient in front of you?
Okay, so if I have the patient directly in front of me, by observing, I would see if the rise and fall stays consistent.
You're telling me about
So
regular, you're telling me about rhythm now. I asked you about depth I said if you have a patient in front of you, how do you know if the patient has good depth?
If they have good depth, if so the depth is the rise and fall. So to tell if they have good depth is basically you're just gonna observe how the rise and fall occurs.
That's it. All you're doing is looking at the chest rise. Can I see visible chest rise? That's it.
Right.
All right. Wilson, Mr. Wilson, what is your understanding of the regularity or rhythm of breathing? What does that mean to you? What is your understanding?
That means how a person, how the person's chest moves at a certain speed. So if it is moving slow, then it gradually increase. That mean that they're having a problem, sir.
Okay. It moves slowly, then increase. Would it be regular or irregular?
That will be irregular, sir.
Okay. Okay. Michael Wilson, Mr. Michael Wilson, what is your understanding of looking for clear, audible breath sounds on both sides? What does that mean to you?
So basically, you're looking for you're listening to the sound of the lungs by auscultation, use of a stethoscope, to hear if there's anything like watery sounds or if there's clear breathing.
Okay, good. If you can hear loud sounds, so you're hearing high pitch, abnormal sounds without putting a stethoscope on this patient, what would you be thinking at that point?
That there's something wrong there, first of all. So
Something wrong? Be more specific, man. Something wrong. What you think is wrong?
high pitch breathing, like wheezing.
I never say no wheezing. I say you're hearing high pitched sounds. It's very, very loud. It's not something you should be hearing. Or you can hear that without putting a stethoscope on the patient's chest. If you had that patient in front of you, what would you be concerned about?
High pitch sound.
We have a whole heap of time to think, you know, a life and death, you know. All right,
Nothing.
go on, think about it. Mr. Johnson, you have a patient in front of you. You're hearing abnormal sounds, high pitch, without putting a stethoscope on this patient's chest to listen to lung sounds. What would you be concerned about?
Check.
Yes, I can hear you.
Well, maybe that patient have some fluid or something inside the lung.
Okay. Would suspect fluid inside of the lungs.
And the cavity. Yeah.
Okay. You suspect anything else?
Mucus or something.
Okay. All right. All right. Okay. All right. So lung sounds should be clear. Now, if you, wherever you put your stats on your patient's lungs or chest to listen, right? If, well, let me not say that. I don't want to go down that road yet. I'm not gonna go down that road right now. I'll wait before I explain that part. Now, it's simple. If there is abnormal sounds without a stethoscope, you need to be concerned about obstruction. That's it. Right? There's an obstruction somewhere within the patient's ear passage, whether that is close to the airway or lower airway. There is an obstruction. Something is obstructing the movement of air, right? We don't have to get too technical, right? When it comes to life-saving cares here, it's actually very logical, practical, and simple, right? All right, so that's the characteristics of breathing. Now, with this chart or slide, I should say, right? Giving you the characteristics of normal breathing. With all of that information in your head, who can tell me what would be the characteristics of inadequate breathing? So based on what you're seeing now on this for normal, what would you consider to be abnormal breathing? Anybody want to try that? All right, so I think Mr. Wilson went up first. Go ahead.
Okay, sir. So if you're presented with a adult and you're looking at the depth of the chest, or there's lack of depth, so there's no adequate rise and fall of the chest.
Okay, so poor rise and fall of the chest, yes. Continue.
Okay. All right, so I look now at the rhythm. So the rhythm, the breathing is rapid, and then it slows down, then it's rapid again, and then it slows down.
Okay, so irregular rhythm. It can be that your patient is breathing very slow, or it can be that your patient is breathing very fast. So it doesn't necessarily have to be irregular. They can be breathing extremely slow or fast, right? Anything else?
I hear abnormal sounds without the use of
Right. So you would be hearing adventitious sounds, which is the same as abnormal sound. Yes. Anything else?
there is no bilateral movement of the lungs.
Right. Yes. If there is something wrong with the pleural membrane, if that's possible, if our lungs collapse, they can see inadequate chest rise bilaterally. All right. Cool. Cameron. So Cameron, you had your hands up. You want to add anything?
Perhaps you're short and shallow, and person probably breathing more from the upper thorax than from the abdominal cavity. So you might
Okay.
realize that there is a bit of difficulty breathing.
Okay. So
And it
I
might
heard
be
shallow.
yes, sir. So short and shallow, and just upper thorax actually moving. It might be rapid.
Okay. All right. So I heard shallow. I heard rapid breathing. So one of the things that you need to look out for is that the patient will be using muscles. You're gonna visibly see muscle use. We call it accessory muscle use, right? So you're gonna start to see the muscles in the neck being used or pulled in between the bones. You can see it in the rib cage as well, right? Muscle retraction. All right, good. So understanding is there. So inadequate breathing pattern in adults, you're looking for labored breathing. Labored breathing means your patient is working to breathe, right? They are working extremely hard to breathe. So If you see a muscle use on exhalation, patient is in serious trouble, right? So if you see a patient that is using muscles, exhale, that patient is in trouble because exhalation is passive, right? Exhalation is a passive process. So if a patient has to work to get air out of them lungs, something is seriously wrong, right? I mentioned the muscle retractions. That's where the muscles start to be pulled in, right there. Muscle retraction. You see that in patients with chronic respiratory problems. The skin starts to get pale, right? So anytime there is a perfusion problem, the blood vessels within the body will constrict. When the blood vessels constrict, it is trying to redirect blood flow to your core organs, brain, lungs, heart, kidneys, right? So the skin is going to develop a pale color. If that doesn't work, eventually the blood will start to become cyanotic, or you start to see cyanosis. Cyanosis is a late finding in your patient. So pale skin, there is a circulation issue. Cyanosis means there is not enough oxygen in the blood. When you start to see cyanosis, your patient is not in a good condition, right? You will see cool, damp skin. All of this will occur because blood is being redirected away from the skin to the core organs. So the temperature is going to drop here. You will start to see the patient tripoding. Tripod, they put the hands on the legs, they lean forward, right? To get air into the lungs. That's what we call tripod position. And you can see agonal gasp. So any bright spark know what agonal gasp is? Okay. Yes, Mr. Wilson.
So,
What is agonal gasp?
so this up associated with pain while breathing. So.
Not at all, young man. Not at all. Anybody else? Anybody else want to try? What is agonal gasp? All right, so let me ask this first. How many persons within the group has done a BLS course before? Raise your hand if you have done CPR, a CPR course. All right. Okay. Quite a few. The people that went to the CPR course, what is agonal gasp? All right, so not quite Miss Lewis. Yes, Mr. Cameron, go.
Short breath, sir.
Shorter breath? No,
A signal.
it's not shorter breath. Shorter breath is dyspnea. That's just difficulty breathing. Mr. Bean. All right, Mr. Beans, may I hear too much feedback from you? So you probably need to go to Cameron side and speak. Yes, Mr. Manning, what is agonal gasp?
Well, I want to go on basically like when they're making desperate attempts to breathe, like like when asthma patients have some really bad issues breathing and they're gasping, something like
No.
that. No? Okay.
Mr. Beans, you find Cameron yet?
Yes, sir.
All right, go on now. I can't hear you better.
Yes, just been in agony, sir.
You know what?
Agony.
Agony?
Yes, sir.
What do you
Yes,
mean
sir.
by agony? What do you mean by agony? What do you
Sir,
mean by agony?
so this is when you have difficulty breathing, but the brain continue to send the signal to the muscle. Brain
You,
send the
you,
muscle.
you are almost correct, you know. All right. So I get what you're saying now. All right. I understand what you're saying. Technically you are correct, right? So what you guys need to understand is that when a patient get to the point that they have agonal gasp, they are unresponsive, right? The brain is no longer functioning, right? They are unresponsive at that point. You will not see a responsive patient with agonal gasp. You're not going to see that. You're going to see this in a patient that is unresponsive, right? So the patient is unresponsive, the brain is not getting proper perfusion. However, as Mr. Bain stated, there is still signals, some electrical stimulation that is going to the diaphragm, but it's not organized, right? So you see the patient gasping or present as if they are gasping periodically, right? No sequence to it. Now, if you have a patient that presents with agonal gasp, you will treat that patient as if they are not breathing. Everybody understand that? So if you have a patient that presents with agonal gasp, you will manage the patient as if they are not breathing. All right, and that's why I asked the question, what is your understanding of agonal gas? If you don't know what you're looking for, you don't know when to treat it or how to treat it, right? All right, good. All right, seems like we have some sharp minds amongst the group. All right, so we have come to the end of the respiratory system. If you have any questions, you can ask. Any questions? Yes, Mr. Wilson.
So, sir, yes, from my understanding so far,
Mm-hmm.
the presentation
Mm-hmm.
is it better you look on the depth, the rhythm, the abnormal sounds, bilateral movement, the movement of the abdomen, and not the rate?
Yeah. So you need to look at the rate, you know. So don't get me wrong. You have to look at the rate, but the rate is not important, right? What is important is whether or not this patient has visible chest rise. Is the breathing labored? Can you hear abnormal sounds, lung sounds? What is the color of the patient's skin? What is the pulse ox? You need to determine the rate, right? But you have to look at other things in the patient presentation. And you always start from the brain, come down, because the brain controls breathing, right? So if something is wrong with the brain stem, something will be wrong with the breathing. So you always start by assessing your patient's level of consciousness. Hello, sir. Can you hear me? Right? Hello, sir. My name is so and so. What's your name? Always start there and we come down. We sequentially assess. So if the upper airway is good, then you focus on the lower airway. You start with the rate, regular. So with the rate, you're looking at, is it fast? Is it slow? Is it consistent? Normal. With the rhythm, we're looking at consistency. And you see a recognized pattern of chest rise on both sides of the chest, right? When you put on your pulse ox, what is the pulse ox telling you? When you listen to the patient lungs, what is the finding? Now, it's not every patient I will listen to the lungs. So it depends on the chief complaint of the patient. So if the patient's chief complaint is specifically a respiratory issue or a cardiac problem, or the patient presents as if they're having a breathing problem, then it's important for me to listen to the patient lungs. So you have to prioritize your management. However, you need to know what you're looking for when you're assessing that particular area of the body.
Okay.
Right? So don't leave out anything. Assess all areas. Don't prioritize that area over any other area. Right? I don't know if that makes sense, but follow your sequence. Once you follow your sequence, you can't go wrong. You're using a sequence to assess your patient. You'll be able to pick up when something has changed. You'll be able to pick up what has changed. But if you're playing hopscotch, as I would call it, I have some persons that have absolutely no sequence in assessing a patient. Jump all over the place. When you jump all over the place, you're going to miss important findings in the patient's presentation. And that, as I say, can mean the difference between appropriate treatment, no treatment, and death. So it's sequential. All right. Okay. Any other questions? If there is no questions, Miss Lewis, I need to speak to you. So you probably need to forward a contact number that I can speak to you, but I need to speak to you at some point today. All right, people, it's lunchtime. Okay. It's lunchtime. We will resume at 1 p.m.
Real quick, sorry, so sorry, I just saw it. Mr. Sarufos?
Yes.
Yeah, before you go, there was one small thing that slipped me. In regards to inadequate breathing patterns. The tripod stand, I didn't quite catch your explanation for that part.
Picture somebody sitting in a chair, leaning forward with their hands on the knee, both knees. Right? So the patient is leaning forward, or sitting around a table and they're leaning forward with the hands, the table or the hands on the knee. That's what we call tripod position. Yes, Mr. Baines.
Okay.
So Baines, you had your hands up. What's up?
The tripod position.
I didn't hear it.
Tripod position, is it one of when the person is standing and they bend over with their hands on their knee?
You don't have to be standing.
Okay, sir.
All right.
Once they lean forward.
Right. So once a patient leans forward and they are struggling to breathe, that's considered potty. All right. All right. It's lunchtime. 1 hour. We will start back at 1 p.m.